Hello, everyone, and thanks for joining the American Ambulance Association today, along with our speakers, Shawn Baird, Senior Consultant of WMK Law, and Brian Werfel, Esquire with WMK Law, Brenda Staffan, Chief Government Affairs and Public Policy Officer with Priority Ambulance, and Tristan North, Senior VP Government Affairs with the AAA, as they discuss navigating the Rural Health Transformation Program, funding, strategy, and best practices. This webinar is being recorded, and the on-demand archive will be posted to the AAA website within 48 hours of the live session. A link to the presentation for today's session will be posted to the chat shortly. Please use the Q&A chat feature for any questions that you may have. And with that, it is my pleasure to introduce our speakers, and you guys can take it away.
Great. Thank you, Kayla. We're really glad to get this started and appreciate everybody's jumping on board to see how much we've learned so far. We have a good group here. Brian will be giving, of course, the legal perspective on things, as well as experience from seeing some of these prior federal grant programs come and go over the times. Brenda, who will offer up her own unique experience, having been with CMMI as a senior advisor on the ET3 project, and also the director of a Healthcare Innovation Award at REMSA. And of course, Tristan North, who has tremendous federal experience lobbying for the AAA and made some very specific endeavors through the AAA in attempts to sort of influence how this program might go and be helpful to our members and others in the ambulance community. So let's take a look at the background of how the funding works on this program. As you've all probably heard, it's $50 billion in the pot, ready to be distributed. That's going to be split into two buckets. One is for every state eligibility that applies, which, if it went to all of them, would be $100 million a year per state. And then the other half is really for those who are deemed more rural than, the greater than 25% based on rural population and other characteristics which would imply that they're of greater rural need. The program itself is going to be administered by CMS through the states as state level grants. So this is really kind of where we get into the meat of it, that individual states in their application are going to discuss what they're going to do with the money. They'll be the state level will be the ones monitoring the expenditure of funds and reporting back to CMS. Next slide there, Tristan. So eligibility, again, it really comes down to the states. We know this has been a little bit of a moving target since the program was first announced, as guidance is, just now kind of coming forward about really the specific details. So even as recently as this morning, we've heard from folks in different states where the states created deadlines for submissions of ideas or interest in participating to provider groups and things as early as late August. We'll talk a little bit more about this as we bounce along, but states have a lot of control over how they put their application together and how they solicit information. The hard deadline that we really need everybody to know is that states must turn that in by November 5th. So the work at the state level, of course, has to be completed as soon as possible in order for the grant writers to get it all put together to turn in by November 5th. The plan is to award for the full 5-year period of funding. So it'll be approved initially for the full 5-year award. But states are going to be required to provide annual reports. And there is the potential that if something went awry or they weren't able to expend the full amount that they were awarded, that money would be brought back into the pot for consideration of redistribution. So those are kind of, some nuts and bolts. Brian, I don't know if you had any other thoughts to add on that.
I do not, but if we move to the next slide, I think now we can talk about what the funds can be used for. So what we're really saying here is those grant programs that states can apply for. So they have to choose at least three from, and there's, I forget what the exact number is, but I think it's about a dozen different potential options. So they can ask for funding to help create interventions designed to either prevent or manage certain chronic diseases. Importantly for us, they can use it with some caveats to provide direct payments to healthcare providers. They can use it to promote what they call consumer-facing tech solutions for the prevention and management of certain chronic diseases. They can use that funding to provide training and or technical assistance related to the development or the adoption of certain technological or technology-enabled solutions to improve care delivery in rural hospitals, including remote monitoring, robotics, artificial intelligence, and other advanced technologies. Again, relevant for us, they can use it to recruit and retain clinicians, or they call it clinical workforce talent in rural areas. They can use it to provide technical assistance, software, hardware, et cetera, to improve efficiency, enhance cybersecurity, and things along those lines. They use the term right sourcing or right sizing, excuse me. So assisting rural communities to right size their healthcare delivery systems by identifying needed preventative, ambulatory, pre-hospital, emergency, acute inpatient care, outpatient, and post-acute care service lines. They can use it to support access to opioid use treatment services. They can develop other projects to support innovative models of care, and then any other use in a rural area that the CMS administrator might deem advisable. So probably where we're going to be focused here is obviously the direct payments to providers. And then they did specifically mention the recruitment of EMTs and paramedics in their documentation. So there are certainly opportunities within the permissible use of funds for our industry. And Tristan, can we jump to the next slide, please? All right. With one major caveat, and that is they don't intend that these funds be used simply to increase reimbursement to providers for services that are already reimbursable under existing programs, such as the existing Medicaid program, Medicare, et cetera, right? So what they're really thinking about is payments to providers for services that are not currently reimbursable. In our industry, treatment in place would be a big example, right? Or where there's uncompensated care. So they're really thinking about expanding the areas of reimbursement as opposed to simply adding 50 or $100 to an ambulance transport that occurs in a rural area. And then this is subject to no more than 15% of the total spending by the state can be based on direct payments to providers. So Brenda, I think I'm going to turn it over to you.
Thank you. Good afternoon, everybody. Thanks for the opportunity to join the webinar. I want to give a shout out to all of the people that have participated in CMS sponsored healthcare innovation projects. I think there were about 6 healthcare innovation awards given to EMS agencies, and there were over 205 participants accepted into the ET3 model. So there's, nearly 300 entities out there who also have experience with notice of funding opportunities, or what is called a cooperative agreement. So again, shout out to the multiple people out there that have had that experience. So treatment in place in the notice of funding opportunity is actually mentioned a number of times. And I'm going to focus a little bit more on treatment in place, but I want to acknowledge there could be multiple additional initiatives, including workforce initiatives and other innovation projects like community paramedicine, which is mentioned as an example in the NOFO, transport to alternative destination, nurse triage, and other EMS-based innovations. So there are definitely opportunities for multiple projects. And seeing some of the letters that have gone from state associations into the states, certainly some of those activities have already been proposed. But I want to focus a little bit more on treatment in place to kind of frame how both the state itself, who is preparing their application, and then also state EMS agencies, and specifically state ambulance and state EMS associations, might support that effort. I also want to give a caveat that I think as Brian mentioned and Shawn mentioned, that some of the state deadlines have passed seeking feedback. And I really personally view this also as an opportunity to continue to be a resource to states as they submit their applications. So I recognize certain deadlines are passed, and I recognize perhaps some decisions have been already made by states, but for the purpose of my comments today, I'm just going to offer a suggestion that we still prepare proposals in writing and put them out there. So in the treatment in place example, the emergency triage, treat, and transport model, or ET3 model, an evaluation report, a formal CMS required evaluation report, was issued in January of 2025. That report contains evidence to support a TIP proposal. And the report indicates that for the participants that had higher volume of treatment in place interventions via telehealth, they were safe, they were effective, and they achieved net savings to Medicare. So what I mean is that there was no difference in hospitalizations and mortality between a matched pair of Medicare beneficiaries that had a low acuity ED visit. And there was also a 15 to 50% net savings to Medicare, or return on investment, for ET3. So one of the things in the NOFO is that it does ask for evidence to support proposals, and this would be a prime example where there's a government report that provides that evidence. Now, granted, the ET3 model was not certified by the CMS actuary to become permanent payment policy. As everyone knows, CMS decided to terminate the ET3 model because there wasn't enough participation by participants, and the volume of submitted claims for TIP and TAD was low. So the model did not continue because of low volume, but the interventions themselves, as reported in this report, actually had some promising results. So here are some lessons learned. I've picked out 3 sections of the NOFO to highlight for today. And I want to connect with what Brian's comments are about reimbursement, because this is where I think there's a nuance that will help identify successful programs. The NOFO will require the states to explain why their transformation projects, or initiatives they call them, are sustainable. So in the treatment in place example in the ET3 model, the major lesson learned, and I think arguably outside the ET3 model, treatment in place cannot be implemented one payer at a time. It's just almost nearly impossible to identify the payer of a patient, and for paramedics and EMTs in the field to offer TIP when you only have Medicare fee-for-service and not all the others. And frankly, with grant funding, it will not be possible to sustain these types of interventions past the 5-year funding period. So we would end up with another great grant-funded project that really is not sustainable. So the suggestion is to consider healthcare reimbursement inside the rural health transformation proposal. And for example, AAA has been requested to consider submitting a letter to CMS and asking for reimbursement waivers. so that if there is a treatment in place proposal and the state is planning to provide Medicaid reimbursement, like some states already have approved, that we could also get potentially a CMS waiver to provide Medicare reimbursement. And that would enhance the ability of that intervention to be successful. Then potentially you go after all the other managed care and commercial insurers. So that's one consideration to take into account. Now, this doesn't have to be done all at once. This could be phased in over the period of the transformation funding period, the 5-year period. And we could rely on the support of our industry's reimbursement experts to really supercharge this activity if more than one state approached it in this way. If there was funding for the operating costs, and I also want to point out, and Brian, maybe you can chime in here. I've not done the math, but the criteria for it to be limited to 15% of the overall funding request could also come into play, where it would limit the scale and volume of interventions with that reimbursement limit.
Yeah, well, I'm trying to do the math in my head, but I think it would depend, frankly, on how many other provider groups would be receiving increased. I interpret it to be 50% of the total.
The whole thing. Yeah. So maybe it's not even available at all.
Right. And I think one thing to consider with all of this is that as you read through the notice of funding opportunity and the example on, for even TIP, it's about treating the, by year 2, their stated example is train 100 EMTs in treat and release protocols. It doesn't say reimburse for treat and release. It pays for the training. And there's a common theme throughout the document, which starts with really, when I think about the governor's endorsement, the references throughout the document to the governor's endorsement and what that should include. And it's a lot about building partnerships, alliances, cross-disciplinary approaches, and stakeholder engagement. So when we think about treatment in place and community paramedicine, for example, a couple of other things that were referenced throughout the document, a lot of those programs, I think there might be angles on getting the funding to develop the partnerships and the regional stakeholder bringing everyone together to get the program put together, more so than the direct reimbursement because of that limitation of 15%. But a bit of a strategic thought about, how to look at that.
Those are great points. And then the second area I kind of wanted to highlight is the evaluation measures that are in the notice of funding opportunity. And I would not underestimate the importance of evaluation measures for all CMS funded programs. They're critically important. They're not going to go away. They're not optional. And the design of the program and the quality of the data are critical. So specifically, the NOFO requires access, quality, and outcomes measures. And this is why I wanted to refer back to the ET3 evaluation report. That report gives details about how CMS measures ambulance innovation and how they identified access measures, quality measures, and outcome measures. And in order for any healthcare innovation to become permanent payment policy, they have to see improvements in access, improvements in quality, and improvements in overall outcomes. So one of the ideas to consider is requesting funding in the infrastructure for a technical assistance center supported by the state's offices of rural health and the EMS office to assist rural EMS agencies, not only in all aspects of whatever you submit, whether it's TIP or TAD or community paramedicine or any other innovation or workforce. But part of the challenge of operating in a rural area and especially independent rural agencies, is how little access to support, administrative support, and expertise across these areas. So I really encourage folks to consider an EMS-specific technical assistance center for the entire period. And that is a perfect example of something that would be funded under the under the infrastructure costs. The Technical Assistance Center can not only have broad assistance, but I also think it would be a perfect place to assure that the evaluation measures are developed properly, the data is there, and also to assure that the transformation intended actually improves outcomes. And there's kind of a linkage between the Technical Assistance Center and the evaluation measures and the scoring points. The better that proposals articulate improved access, improved quality, and better outcomes, the higher score you're going to get, and the better opportunity that the EMS component of the state's proposal will actually be awarded funds. So please do not underestimate the importance of this. The ET3 evaluation report, while it is long and it's detailed and it's a technical read, there are some examples in there about how CMS evaluates that. And I have a couple of more comments, but I'm just going to pause and encourage dialogue here.
Well, I think those are great examples of how people can go about pursuing these. We've seen a number of different approaches. I think some highlights there that Brenda made about making sure that we really fit within the criteria, work off of the examples, look for solutions that are policy drivers, technical assistance oriented, not so much direct reimbursement, and make sure that they meet the evaluation criteria, which is published in here, what they're looking for. EMS solutions represent just under 4% of the points awarded. So while it's an uphill struggle for 4%, even if you got all of them, for 4% to move an award, I think states will not want to ignore the fact that they're called out and have specific scoring criteria. So I think that plays in favorably in an application to have it in there. And certainly that can bolster a state's application to know that they're going to get 4%, 3.75% of the points if they do have this component in there. I think, why don't we move on to the next slide a little bit with Tristan about how AAA's participation and how we've got going. And then as we kind of do some wrap up, we'll loop back around to a few other points to make.
Yeah, thank you, Shawn. So the AAA was focusing on 3 areas with the One Big Beautiful Bill Act, HR 1, which was the creation of this program. First, obviously, trying to mitigate changes with Medicaid requirements for beneficiaries, which we were working through the Modern Medicaid Alliance, a group or coalition of providers, also patient groups. Actually, AHIP, the insurance provider group, was the one that was the primary organization working with the coalition. So had really tried to mitigate some of the impact on the eligibility requirements. And then number 2, also working through that group as well as directly through the AAA membership and our efforts here in the DC area to also mitigate changes with the with reduction in the provider tax. So we did see some beneficial changes there after the initial Senate bill was introduced, as far as pushing back the timeline on that. And then the third area was the development of this program dealing with rural healthcare, which was intended to somewhat mitigate. It's obviously a small piece of the changes within the Medicaid eligibility, but at least something that we could ensure that our members would have access to. So there were a couple things when the Senate Finance Committee released their report. It was originally, or their draft of the bill, it was originally $25 billion. And while there was language in there that did not prohibit ground ambulance service providers from being part of a state plan and thus eligible for funding, we all know that sometimes when dealing with states, unless Congress is explicit, folks run into issues. So we worked with Senator Collins, Republican of Maine, as well as a number of other Senate offices, but she was actually the author of the amendment during floor consideration of H.R. 1 that added an additional $25 billion, or would have added an additional $25 billion, as well as it specifically cited that ambulance services are both eligible entities as well as eligible services that can be part of a state plan. Now, that amendment, unfortunately, handily was defeated for a couple of reasons. I think the final vote was 22 in favor and 78 against. But the offset within the bill was actually reverting back to previous 2017 tax levels for those individuals who make $25 million a year more, or married couples that make $50 million a year. The interesting part there is that you actually did have 18 Republicans, even with that offset, who voted in favor of the amendment, as well as 4 senators who caucus with the Democrats. So while it did not succeed, the Senate Finance Committee in their underlying bill ultimately did, as a result of that, bump up their figure from $25 billion to $50 billion. Also, the good news was immediately or shortly after passage of H.R. 1, we did see a number of senior CMS officials. In particular, I think there was a National Conference of State Legislature meeting in Boston in August that made clear that ambulance services and emergency medical services are part of the state plans. So very good news, as reported by others within the outline today. And we have seen other references and inclinations from the administration about the importance of ambulance services. In particular, RFK Jr., when he was going through his Senate confirmation process, and traditionally you meet with senators on the Committee of Jurisdiction to ensure that they don't have any questions and hopefully secure their vote, had met with Senator Cortez Masto, a Democrat of Nevada, our lead champion on the Senate extenders bill, and not prompted, he actually stated that there needed to be something done for rural ambulance services. So obviously his staff had well prepped him, knowing that Cortez Masto was a strong opponent or proponent of ambulance services and thus should bring up that issue. And then since the release of the application, we have been following up directly with the administration, and actually AAA President Jamie Pafford Gresham about a week and a half ago did have a meeting with senior health staff at the White House, and the Rural Health Transformation Program did come up, and we are working on a follow-up letter from her to the staffer that basically outlines that if a state plan does include a funding program for ground ambulance services, that program should be fully funded regardless of the amount of money that is ultimately allocated to the state for coverage of their plan. As Shawn had outlined earlier, each state automatically gets $100 million a year, then it's discretionary, the additional overall $25 billion. So likely states are going to ask more than that they ultimately receive. So we want to make sure that no matter what is proposed within a state plan for ground ambulance, that there is special emphasis placed on making sure that the total amount of funds go, regardless of the overall amount that goes to the state, that the overall amount does cover the program within that has been outlined for ground ambulance services. And then
That's
go ahead, John.
I was going to say that's great, and certainly a tremendous amount of work going into kind of maneuvering along to make sure that ambulance services have their fair and full shot at things to come out of both this program and others, and the relationship with being able to work with both congressional leaders and the White House on this. I think you see the results of that both in the notice of funding document and as we move along and kind of see where states go with things. If we could click over to the next slide on some of the key takeaways. We made several points about considering that EMS is going to clearly be a part of many states' applications, as it well should be. That ground ambulance service organizations specifically really need to engage. If you haven't already, now is the time. Even if, as was mentioned earlier, your state had a specific deadline of sometime in the last 2 weeks or something to have turned in proposals, still turn in a late proposal, because those are just state guidelines. They have until November 5th to turn in their final application. And if you're not out there talking to them, they're not hearing you. And they'll be hearing from a lot of people. Many states already have, there was posted a website that's tracking states' activity on these applications and the processes they're going through. And most of the states have already had hundreds of ideas submitted. So you really do need to have your state in the mix. And partnerships are going to be critical to this. I was looking back over this morning in the notice of funding. Early on, once they go over all the sort of details on eligibility, they talk about program requirements, expectations, and the use of funds. And EMS is ideally suited for several of the initiatives where states have to as we kind of mentioned earlier, states have to hit at least 3 of the dozen or so aims. Luckily, because EMS is that sort of catch-all that doesn't necessarily live in any particular house, but a little bit of all, we crash into all of them. The fact of the matter is I was looking at, training and technical assistance, workforce development, innovative care, and fostering collaboration. You can hit 4 or 5 of them just with a MIH program or a TIP program, all of which are so cross-disciplinary. So I think, it puts us in a great spot. If nothing else, and if we could move on to the next slide, and then we'll open it up to discussion. But I wanted to say, if nothing else, these applications present an outstanding way to advocate what's going on in your home state and what EMS needs are, what ground ambulance service needs are, regardless of if you ultimately get included or not. And I don't mean that to be discouraging, but rather encouraging. The process of educating the policymakers in your state through advocating for inclusion is a part of your ongoing lobbying effort to make sure you're recognized for the healthcare activities that you're undertaking in your state. And I'd love to have some comments from the other panelists around the takeaways.
So I'll start, and I'm going to start in the form of a question, and I'll pose it to Brenda. So one of the questions that I was asked several times in the last couple of days was, strategically, do we think it makes more sense to sort of cast a wide net with a large number of potential initiatives, hitting everything from the staffing to the reimbursement, or does it make sense to be more targeted in our ask for inclusion at the state level? I can see the merits of both, but
I can see the merits of both as well. But my comments earlier about the evidence and the required outcome measures, I would, and again, this is, you literally just asked me the question, so this is off the top of my head. I would lean towards programs that have evidence and can be taken to the next level. And it can be community paramedicine. There are community paramedicine programs in rural areas. And I would also look at programs that cross all of these criteria. Again, evaluation measures, sustainability, that we need reimbursement post. In 5 years, there needs to be healthcare reimbursement because there won't be this funding. This funding will go away. And partnerships. So I would prioritize interventions that meet all those criteria. And so, for example, I didn't talk about transport to alternative destination. I specifically know of rural agencies who use transport to alternative destination in partnership with their rural healthcare center, or the equivalent of a federally qualified healthcare center, to get rural patients to urgent care instead of an ED that's 3 hours away. So common sense things, but that have evidence, have partnerships, and can be evaluated, and can get healthcare reimbursement post grant.
Yeah, I think I would tend to agree, Brenda, and I think that some of those things, like that alternative destination, that involve a bit of a policy change, are probably going to be favorably viewed. Just sort of seeing what's come out of the administration over the last several months, that they're really looking to drive some new initiatives, like not just find a different way to pay for doing the same thing over again, but something that kind of really moves the needle in terms of the policy on how we deliver care to people, improving access to care in rural areas, top priority across both Congress and the administration. So those kind of things tie right into that. Probably going to be favorably viewed. Kind of a different answer, I guess, to Brian's question would be, okay, those are targeted, rather focused, with evidence to pursue them already. An alternative tactic, one that I've worked on in another state, is to piggyback onto a transformation, an EMS transformation project that was already underway. So out in Oregon, we had a key champion in the legislature who happens to be a paramedic as well, who put together a broad coalition and passed some transformative legislation that really looked at multidisciplinary regional approaches to planning for delivering care to improve access, quality in the workforce. Some great framework put together, a lot of it based on providing technical assistance and moving technology forward. Unfortunately, the legislation was passed, but it wasn't funded just in the last session. So we looked at this as a great opportunity to say, hey, Governor, you know, we all bought off on the legislative effort. There was broad support for it from across the legislature. Now let's look at getting it included in this to fund it, because many of the planks crossed over all of the same goals and outcomes desired by the Rural Transformation Grant. So totally different approach. Remains to be seen how well it's received, but I think both have very valid thought process behind pursuing them. Tristan, any more further thoughts from you?
No, I mean, I just want to make sure that as we go back to key takeaways, I think each of the speakers said this, but there is kind of a typo within that first line. You know, we are specifically listed as eligible providers and services as emergency medical services, while not specifically ambulance services. Emergency services definitely, medical services definitely does cover us. So just want to make sure that anyone who had seen that particular point, there was no confusion there.
Yeah, excellent point to make.
So we do have a question, and I guess I'll morph into the moderator because someone else also texted me a question, but um, we'll pose it to Shawn then. So the question is, to the extent that there's an innovation that's designed to improve rural care as part of a grant proposal, but if it were implemented statewide, it would also benefit urban providers, is that potentially problematic?
I don't think it's problematic. It's probably all in the presentation, right? In terms of what are the real first primary objectives that you would want to highlight to hit on the rural, of course. But if there's a bleed over effect, I don't know that it would necessarily detrimentally affect the scoring. Others, what do you think?
Actually, Brenda and I had a conversation about this very item on Friday, and I would say a couple of things. First of all, I think it'll very much come down to your state and their determination of how they want to implement these, because we thought it would focus more on the area of care provided or the community of care, and that be rural, and not necessarily where the ground ambulance organization is physically located, right? Where their main facility is, because you've got a lot of folks, and I think we were using Nevada as a good example of where you've got these very large rural counties or rural areas that sometimes the county can be considered urban because it touches a large urban area such as Las Vegas, right? So we were actually thinking probably the best suggestion as far as determining rural area probably would be the Medicare ambulance fee schedule and that definition, because you've got the Goldsmith modification that takes into consideration that you're going to have some very rural zip codes in some very large urban size-wise counties. So as much as you can, using a definition of rural that falls within the guidance of the application, but also, right, kind of benefits ground ambulance services in the communities that everyone serves. Because I think it's going to be potentially different for each different program as to what's determined as rural.
Right, and if you want a particularly easy example of this, the one cited by CMS, which would be to use the funding to train new EMTs and paramedics in treatment in place protocols. Once they are trained, there is no guarantee that they will not end up working in an urban area, right? But the premise is that many of them would elect to ultimately seek employment in rural areas, and therefore that would, help create the access or improve the access in those rural areas. So,
right.
I realize that money is fungible to a large extent. So
yeah, and using your example, Brian, also it may not be necessary or requirement that the training occur in a rural area, right? You might have the only training facility is in an urban area, but then that facility serves rural, paramedics and EMTs who are then going to serve rural communities.
Right.
So,
Nevada's a great example.
Yeah.
Well, it would logistically make sense to locate it in one of the major cities, even if the intent is that the majority of the individuals might ultimately work outside that city. So
I think
I think
the NOFO also doesn't say specifically networks that are based in urban areas, but there is a lot of language in there about integration, about partnerships, regional partnerships, economies of scale. So I think engagement with rural partners is not prohibited in any way or would be seen as long as the focus is on the care delivered in rural areas.
Yeah, and particularly where you may have innovative care models where you're accessing expertise out of an urban large health system, university health system, but leveraging that to provide access in some form or another in the rural area. So you're going to see a lot of those kind of crossovers, I think.
And I think all of this just highlights the critical need to work closely with your state officials, right? It's not a submit a program and hope it gets signed off on. There's going to be a lot of flexibility by the state. So you need to be making sure that you are working with them to assure that each of your programs, their guidelines kind of meet within what the state plans on doing with the funding ultimately. So.
Yeah, and Tristan, that just got me thinking that, you know, if you put yourselves in the position of the state official that's really seeing all of the submissions coming in, whether that's your, you know, health authority director, someone in the governor's office, however that's being done within your state, there are a handful of people who see it all and are going to be able to identify, oh, we got this really big one from some prominent healthcare, you know, entity within the state, a health system delivery model, and then we have this EMS, and I see the bridge between the two and can kind of start linking, like, whereas the EMS as a standalone might look like, you know, it isn't, they don't necessarily draw the connection to how it fits with everything until they're looking at all of them together, and they can say, oh, maybe we could actually leverage our EMS partners within this application from the university health system or whatever it might be. So I think there are some real opportunities there, but it's going to take quite a network for them to come together. Are there, I'm not able to see the chat group at the moment, but are there any questions coming in that, or by text for anyone else on the panel?
Shawn, I'm not seeing any questions. Does anyone have any more questions that they wanted to put in the Q&A box at all for our speakers?
I guess there are going to be, you know, for those of you who are AAA members, we do have some materials that are coming in from folks that are working on programs within states that are being shared. And certainly email the AAA staff to request access to those if you haven't already seen them. Some of the initial letters of proposal to state governors and health leaders are available. Brenda, I think if I remember right, you were going to put some TIP information together.
Absolutely. And yes, including kind of a summary of the treatment and place evaluation done by as a part of the ET3 model.
Excellent. And so we can push that out to those of you who were registered on the call and also make it available through the AAA. Any final comments from the panel?
Yes, we have just a comment. Christopher Hall is just asking if the slide deck will be shared with attendees. Christopher, it is in the webinar chat, but it will be added to the AAA website too within 24 hours, and that will be a link to the on-demand slides and this webinar. But if you did want a separate copy, if you wanted to drop your email address, I am happy to send you a PDF copy right now.
And we will also update the slides to correct that one bullet that I had mentioned.
Okay, any other questions at all? I don't see anything popping in.
Great.
Okay. Oh, actually just one more here. Dennis is asking, any thoughts on the necessary changes for EPCR modifications, also the need for shared data?
I can take that. So I think that question kind of relates to my earlier comment about evaluation. The states must evaluate these grant projects. It's like literally a requirement. And in fact, if data is not submitted successfully, they can defund projects midstream. So it will be a requirement. And so a second piece of that is the NOFO encourages data sharing. So that means putting data into HIEs and submitting data to CMS. And as the question points out, EPCRs may need to be modified. All of these areas could be part of the infrastructure submission. So updates to EPCR systems to integrate data. And I'm just going to make one more comment regarding why it's critically important to gain post-grant reimbursement, which that process needs to start in the design of your proposal. CMS evaluates access, quality, and outcome with claims data. That's what they use. Not necessarily EPCR data directly. They use claims data. So how can they know if you increase quality in an EMS-based innovation? Well, they can measure mortality, hospitalizations, return to ED, primary care visits using claims data. So that would be another, in this whole area of data, that would be another rationale for focusing interventions on those that either currently are reimbursed or would be planned to be reimbursed.
Great. Okay.
All right, it looks like that is it for questions. So again, thank you so much to Shawn, Brian, Brenda, and Tristan. And again, thank you all for joining. And just a reminder, the webinar will be posted to the AAA website within 48 hours. And with that, we hope you all have a great day.